Fantastic. Good day and welcome to this session of the Summit 2021 Annual Conference, Growing MedTech Post-Pandemic, Adaptability, Resilience, and Sustainability. I am Tapiwa Tevera, member of the Summit Transformation Committee, and I'll be facilitating this session on transformation in the healthcare sector. And the question is, what can medtech companies do to grow our healthcare workforce? The pandemic has highlighted the healthcare workforce shortages, right? And in a recent media article, there was quite an alarming figure to show the number of nurses who are going to retire in the next few years. So framed within the context of transformation, this session aims to unpack the capacitation of the healthcare workforce while simultaneously supporting job creation and contributing to a sustainable and resilient healthcare sector. And we're really delighted to be joined by Dr. Gavin MacGregor, who is the Director of Umthombo Youth Development Foundation, a nonprofit organization investing in rural youth to address hospital staff shortages. Dr. MacGregor joined the organization in 2008 as the first staff member. And over the last 13 years, he has seen the organization grow from supporting 60 students a year to now supporting over 200 rural health science students per year. Colleagues, I ask you to make use of the chat function or the Q&A facilities to ask questions or to post your comments. And with that, I would like to hand over to Gavin or Dr. MacGregor, and we look forward to learning more from you this morning. Over to you.
Wonderful, thank you so much for the opportunity. Let me just get this going. To share at this wonderful conference and to share a little bit about our insights in training healthcare professionals. Thank you for the introduction. And I think as was mentioned, COVID-19 has highlighted the desperate need for healthcare workers, and that's throughout the world. But you can imagine in areas, poorly resourced areas, rural areas, the challenge is even greater. So we face this challenge of shortages of healthcare workers, and at the same time, we've got huge numbers of youth in South Africa, neither in education, employment, or training. And so how do we fit these two together to try and address the critical shortages in the healthcare sector? And then we don't just need numbers of healthcare workers, but we need properly qualified and empathetic and competent healthcare workers. And so how can we bring all of these things together and get the medtech companies involved in this innovation? I'm going to share a little story about the Umthombo Youth Development Foundation. We're a non-profit organization, and it started in 1999 out of a desperate need to address staff shortages at a district rural hospital called Mossveld Hospital, situated in northern KwaZulu-Natal. I'll show you a map just now, but bordering on Swaziland and Mozambique. And the concept was to invest in local youth to study health science degrees with the condition that when they qualify, they would come back and work at the local hospital. So in 1999, the program started with the support of 4 youth. And now we support annually between 180 and 200 students a year. And we've produced 488 graduates. And I'll give you a breakdown of that a bit later. So this is the location where our work is taking place, mainly in northern KwaZulu-Natal. We do partner with 2 hospitals in the Eastern Cape, but very rural and remote areas. You can see Mossveld Hospital in the top corner there. On the left-hand side is Swaziland, and ahead of that is Mozambique. So very rural and remote. So the question is, why invest in rural youth? Well, because they come from rural areas, it's been shown that healthcare workers of rural origin are more likely to live and work in a rural area than their urban counterparts. So that is a positive. And of course, when qualified and they're delivering service, they understand the language and the culture of their patients, which leads to a better experience for the patients. And then there are many rural youth that exist, but most of them don't have, and they have potential, but they don't have the means to study or even the knowledge of how to navigate that higher education journey. Of course, investing in rural youth comes with some huge challenges because of the non-fee paying schools that they've come from. They are poorly prepared both academically and socially for higher education. And that's where we step in as an organization. So we have a compulsory academic and social mentoring support program, which all our students participate in. And the program helps them identify the challenges, find solutions, and we hold them accountable to implement the plan. This is a picture of the model we use. So you can see the local hospital is in the center because ultimately we exist. We're a non-profit organization, but we exist to address staff shortages at that local hospital. So as an organization, we get involved in marketing to schools, informing rural learners about health sciences as career options. And most of them would know about a doctor and a nurse, perhaps a physiotherapist, but they wouldn't know about some of the other disciplines. And so we make them aware of what those are and what are the subjects and grades needed to study those different disciplines. Learners that are interested would then go and attend a hospital open day where they have an opportunity to meet graduates and healthcare workers. And if they are serious and they want to choose to study one of the health sciences, they then need to do 1 week's voluntary work at the local hospital so that they get an understanding of what a pharmacist does, what a physiotherapist does, or what a nurse does. And then ultimately they would be called to a selection interview after completing the paperwork. And the hospital, the local district hospital, is involved in selecting the students who we will then support, and ultimately the hospital will employ. So the students go off to university, and that's when our intervention kicks in. We provide financial support, but the critical aspect of our work is the academic and social mentoring support. A big advantage for our students come their June and December holidays. They go back to their local hospital where they do holiday work. And this helps them to complement their theory with practice. They're also able to learn in a non-threatening environment, and they start building relationships with the hospital staff where they ultimately will be employed. So when they finally graduate, they're employed by the local hospital through agreements that we have, or else another hospital in another district, or one of the public sector hospitals. So how have we done in terms of this journey? As I mentioned, we invest in rural youth who are poorly equipped for university studies, both academically and socially. They have the academic potential, but through our support, our students have achieved a 92% pass rate at university over the last 10 years. And that is exceptional. It's way above the national norms. Here are some data that we can compare with the national averages. So in the top rows of this slide, those are the national averages of throughput rates of medical students, so students studying to be doctors. And after 6 years, about 70% of them would have completed their qualification, whereas our students, 82% would have completed. And after one additional year, the national statistics are around 82%, 98% of our students would have completed their qualification just with one additional year. And if they need, if we take 2 additional years, we basically accounted for all of them. Here is a slide of showing the breakdown of the 488 graduates. And you can see that we purposely invest in health science disciplines, 16 different health science disciplines, so that we can, a district hospital can offer comprehensive healthcare delivery. So the therapists, the doctors, the pharmacists, the radiographers, and even biomedical technologists, because that is a critical function of getting blood analyzed and getting results back to the doctor to make a timely decision so that intervention can be implemented. And yeah, we've got some incredible stories about the impact of these graduates, and I'll speak about a few of them later. But also significantly, over 50% of our graduates are women, and people might say, well, yes, in the healthcare sector, that's normal, but in a rural setting, that is not normal. So this is exceptional. When this program started in 1999, people were very critical, and they said, well, firstly, you wouldn't get rural students who would be able to get into university. And we've shown that that is not true, because they are, through their matric results, able to access university. And then people said, well, they wouldn't succeed. And we've shown that we can get a 92% pass rate from rural students. And thirdly, they said, well, if they did succeed and they did qualify, there is no way they're going to go back and work in a rural hospital. And here's a slide which just tries to show you that over 60% of graduates have gone back and worked at their local rural hospital. And in terms of retention, because one of the issues is you can get people to go to a rural area, which community service does, but often they don't stay. And so the little piece down at the bottom there shows that 65% of our graduates stay on in a rural area long term. So that is beyond the period that they were required to work there. Currently, we're supporting 169 students. We're very low just because funding uncertainty at the moment around COVID. We've been very conservative, but we should be supporting over 200 students. We could support between 350 and 400 very easily with the type of support systems we have. We have local mentors on 16 different campuses, and so we have the capacity to support many more students. But again, this slide just shows that we're supporting students across a wide range of health science disciplines. So what is the impact of this work? Well, we've got youth qualifying as healthcare professionals. They're going into employment and they're earning a salary. And I think we would all agree as a country, we need more people in employment than people on social grants. And rural areas are notorious for, you know, the large percentage of the population on social grants. And so we are changing that narrative. We're improving healthcare service delivery by training youth who come from an area, go back and are able to communicate to their patients in mother tongue, they understand the culture, and therefore the delivery of the service or the patient satisfaction is better. They, as young graduates, are investing in the education of their siblings, having now seen the value of education, or their own children. They're building houses, they're purchasing cars, property, therefore ultimately stimulating the local economy. And then a very important thing is they're serving as role models to the youth. They're showing that it is possible. If you work hard and you apply yourself, you can qualify as a healthcare professional and go into employment and change your life and your family's life. So in 2016, we got a health economist to look at some of our data to see what is the greater impact of this work. And so this slide shows the cost of training 254 graduates was 186 million. The income tax that they would pay over their lifetime is 1.2 billion, and their lifetime earnings is in the order of 4 billion, showing that the investment is tiny compared to the return to the country in taxes and to the greater economy. but now that is looking at them in the future. During our lockdown, hard lockdown, sitting at home, I sat down and I tallied, pulled out some spreadsheets and wanted to understand how much would our current graduates, so 379 graduates at the end of 2019, so over the period 2002 to 2019, how much would they have earned currently? And you can see the total down here. The combined 379 graduates would have earned over R1 billion and paid in the order of 273 million rand in tax. And our cost of investing in them, training them, providing comprehensive financial support, mentoring support, cost 271 million. So we can see that the taxes alone have covered that cost. So the return on investment is excellent. And so this leads me to the opportunity that medtech companies can start being involved in this type of equipping of young people for employment. And BEE is an ideal opportunity for that. So you would all know your BEE scorecard consists of ownership, management, development, enterprise and supplier development, and socio-economic development. Skills development is what we're going to be talking about today. It is a priority element, meaning that it needs to be part of every company scorecard. And there's a potential, you could score 20 points, but actually you could score 25 when the graduate goes into employment. And all our graduates are employed. So that is, those 5 points are considered bonus points for employment. The skills development codes allow companies to support training of non-employees. So the previous codes only allowed you to invest in your own employees or their dependents, but the codes now allow you to invest in skills development of non-employees. In our case, all the beneficiaries of our work are Black. They originate from rural areas. More than 50% are female, and they all go into employment, meaning that you could score those 5 bonus points. As an organization, we are able to provide details of the beneficiaries, including names, ID numbers, copies of their IDs for verification purposes. In addition, we're a non-profit, and so we are able to issue companies with an 18A tax certificate, meaning that you're going to get a tax break on the money that you invest in your skills development through our organization as well. And critically, your company is going to be involved in addressing skills shortages, and especially amongst the youth, which is a critical need at the moment. So what will that support lead to? The money will help support students to receive the academic and social mentoring support, which is going to increase their chances of success from around 50% to over 90%. Yes, believe it or not, about 50% of university students will fail, or only 50% of them will be promoted in 1 year. The contribution will also ensure that the students experience the world of work when they do their holiday work at their local rural hospital, helping them to complement their theory with practice. And it would also support the costs of life skills workshops that we provide to our students to help them attain the soft skills, communication skills, things like that, which make them good healthcare professionals. And it would also provide the necessary top-up funding to supplement the NSFAS, the National Student Financial Aid funding that the students currently receive. The breakdown of what this cost is: the top-up allowances, food, books and minor equipment like stethoscopes, lab coats, scrubs, those are the things that we cover. And mental health has become a big component that we've had to include. Interestingly, we included this component before COVID, but it has become a much greater need Some of you may be aware that, you know, all campuses closed, students had to return home within 72 hours. But being in a rural area, they faced many challenges when the universities resumed online teaching and learning. And so mental health has become a very big component of the support we provide. And then the academic and social mentoring support, which entails a student meeting with a mentor, so a face-to-face meeting once a month with their mentor to help them navigate the higher education journey, the life skills workshops, which I've spoken about, and then the cost of the holiday work. So for a mere 44,000 Rand, you can help a rural health science student succeed in qualifying as a healthcare professional. And actually this is an investment because the majority of their fees are being covered by the National Student Financial Aid Scheme, which is government, which is ultimately our tax money. So this additional investment is going to ensure that they succeed rather than fall out after a couple of years of studying at university. And you can improve your BE team building. We can give you stories of the students and how they're doing. And so you can use it really to knit your company together by showing them how you're investing in youth in the country. Your skills development spend will create new taxpayers who've got disposable income, which I mentioned earlier is what we all critically need. And you'll be assisting to reduce youth that are neither in education, employment, or training, as well as decreasing youth unemployment. And so as I conclude, we've been talking about the numbers and how it all works, but here are some of the real beneficiaries, some of our graduates. So these ladies at the top left, they're all medical doctors from UKZN. The guy in the bottom left, Spamandla, he was the first psychologist that we trained, qualified in 2010. He went into a district of 550,000 people as the only psychologist in the area. Through his work in the area, he ensured that posts were created at the four additional hospitals, and within 3 years of him working there, there was a psychologist at each hospital. The lady in the middle, Nelly Umthombo, she's a pharmacist, and she qualified, finished her matric at Umthombo, the local school. She had an excellent matric results. She had no money to go or even dream about anything. She spent 4 years in Umthombo doing odd jobs until she heard about our program, and she went to Wits to study pharmacy, and she flew through her degree, completed in a minimum time, and qualified as a pharmacist and is working at Mossveld Hospital. She's the head of pharmacy at that hospital. But it just shows the latent potential. Here was a lady who spent 4 years just with no options. And as soon as she got that opportunity, went to university, her fees were covered by us. She received some mentoring support. No hiccups, got through in 4 years. The lady on the right is Lungile Hobe. She's one of our trustees now. She's a family medicine specialist. She works at Umseleni Hospital. Interestingly, her mother is a cleaner at the hospital and always had a dream that her daughter should become a doctor. And so Lungile fulfilled that dream. And here we have Selinkosi. He's a speech therapist. He is actually severely short-sighted himself. So he sat at school with a pair of binoculars right at the board so that he could see what was written on the board. He went through his entire university education with a pair of binoculars and qualified as a speech therapist and went back as an inspiration to his community. So you can imagine what change he can bring about. And then Zachariah, the nurse at the top, he's worked in his community for over 16, 17 years now. Married a local lady, got his children in the local school, And so these guys their lives have been changed radically, but it was not through, it was through their hard work and our partnership with them, our encouragement, financial support, which was critically needed, and our mentoring support, which is walking alongside, encouraging, helping them address the issues they face. So I thank you again for the opportunity to address this conference, and I trust that organizations would be interested to contact me, and let's get involved and help develop the skills that we need in our country. Thank you very much.
And thank you for telling us more about how we can, play a role in capacitating the healthcare sector, primarily in rural environments. Now, we've got a number of questions that I would like to draw your attention to. Let me just have a look here. So the first question is there any opportunity of taking this initiative further than KZN? And if so, just to add, what would the timelines be for that?
Wonderful. Okay, thank you for that question. Very apt. We have a model that can be moved anywhere. So we've worked in the Eastern Cape. We were going to work in Limpopo a number of years ago, but then the Limpopo Department of Health moved under administration and everything stopped. So there's different ways that this model can be replicated. As I was saying, the critical component is our support to students, and we have a presence on 16 campuses around the country. So that's a national footprint. So any student studying at one of those 16 campuses can receive the support that we provide. And then if we look at that model where we had the local hospital in the center, that could be your company. So that could be your company as the main source. And students you're recruiting students, you're sending them off to university, they're being mentored either by us through our network that we currently have. They return to you for work exposure, and ultimately you employ them in your company. So there's many ways this model can be used, but it can be replicated quite easily.
Okay, thank you for that. And then the next question is, our sector works through a certified QMS, ISO 13485, right? Clause 7.2, customer related processes, which calls for us to do user training, which can be part of the academic curriculum. So how can the device sector therefore contribute and benefit in conformance to the QMS requirement?
That's a high-grade question. I'm not sure. I don't know how to answer that. I'm not very au fait with the QMS framework and so on. Yeah. So maybe
can I invite Simone to unpack that question further? Tech team, are we able to unmute Simone Rudolph Short?
Can you hear me, Tapiwe?
Yes, we can. Yes, we can.
Okay, thank you for that. Yeah, when it comes to our sector with all the various devices which are obviously used by the healthcare practitioners, a lot of their training would be around the therapy and the treatment around these devices. How can the sector participate with these schools in actually being able to report and record this training, which will obviously benefit us in conformance with our regulatory requirements? In other words, could a company participate in a certain part of a curriculum, like wound dressing, for instance?
Yeah. That's a very interesting take on it, but I think the discussion then would have to be with the academic institutions, so the medical schools, the health science faculties, because that would be very relevant about giving the the students the correct skills and the new technology that you guys are, clearly I've been listening to some of the conference this morning, and it's cutting edge stuff. So, and ultimately we want our graduates to qualify with the latest technology or a knowledge of that technology, what is available. So I think, but I think it should be directed towards the faculties and different universities, health science faculties and medical schools directly.
Okay, thank you. And then there's another question about, is 44,000 Rand per student? Is it 44,000 Rand per student? And I see that you responded by saying yes, it is per student.
Yes, so it's 44,000 Rand per student per year. That will ensure that they get top-up financial support, which is extra money for food, books, stethoscope, lab coats, professional fees, whatever is needed, as well as that meeting with a mentor every month and a life skills workshop and paying for their holiday work. Getting there, they get a stipend while they're doing their holiday work and covering their food and so on. So yes, that's what full cost is.
Okay. And then there's another question about, do you have a comment on the limited spaces available to candidates at medical school in South Africa? So Madeleine, I'm not sure if you would like to unmute and to further unpack that question.
Okay, can you hear me?
Yes, we can.
Yeah.
Okay. No, I just wanted to ask Dr. MacGregor, you know, obviously there's such pressure on students to get into medical school. You know, if you have matric pupils nationwide of all backgrounds trying to get into medical school, it's almost like a mythology. You know, you just can't get into medical school. It's impossible. So, I mean, first of all, kudos to the incredible work that you've done. I mean, I know that region up in Northern Natal, and I know how completely, you know, remote and rural it is. And it's just so inspiring to hear what you've been able to do with the young people there. And it shows that you can uncover talent in the most unlikely places. But what I'm really asking you is, has anything been done with the forums that you attend or the, you know, networks that you have to actually expand the capacity in this country to train medical professionals, you know, maybe with more places at medical school or alternative pathways to qualification? That's what I wanted to ask. Thank you.
Yeah. Great. Thank you for the question. Yes, I think that the government is very aware, and the previous Minister of Health had met with the medical schools specifically to ask them to increase their intake, and some of that happened, but it's still woefully small. But there are a lot of issues. Number one, the number of lecturing staff available. So classes are really getting bigger. And so you've got to still have enough contact time. So yes, it's a huge thing. They've opened a medical school in Mpumalanga to try from that angle. So I think the universities themselves are very aware of it. The Department of Health is very aware of it, and there are no short and quick answers. Unfortunately, some students have been sent to Cuba for training, which is not, we don't see that as a good alternative. It's a very expensive alternative. Those graduates come back are not really fit for our South African healthcare system. So yes, but I think the government is trying various options, as well as the universities, to try and increase capacity. There are certainly enough applicants, young people willing to study medicine and the whole range of health sciences. And it's not only medicine where there's limitations, occupational therapy, speech therapy, all those types of things. Select very small numbers of students annually.
Okay. All right. And then carrying on with the questions, do you work with any of the CETAs?
Would love to. Quick answer, yes. CETAs seem to be, I don't know if there's anybody there on the CETAs, but they seem to be a law unto themselves. We try and work with Health and Welfare CETA, and we registered, and they should know what we're doing because we let them know. And I would think that this is where the money should be coming from, but they don't seem to think so. There seems to be a huge disconnect about how, for example, I see CETAs, what their role should be, and what the way they see it. Because after we all registered in that, they said, well, you can apply for a project. I said, we are the project. We're needing money from you to skill these young people so that they ultimately can go into employment. So if anybody's got any contacts with CETAs or knows how they function properly, we would love to connect with you, because yeah, we do need help in that area. And I think it would be a huge opportunity to tap into skills development funds that already companies have paid across, you know.
Absolutely. Thank you for that. Then the next question is around the payback period or process. Does it work similar to NSFAS?
Yeah, so in our situation, what we were saying to students is, for every year that we support you, we want you to go and work back in your rural community for the same number of years. So if you're doing a 4-year qualification and we support you for 4 years, you're committed to go and work back for 4 years. Now that worked very well from 1999 to probably about 2017, 2018. Where we were a full cost funder, we actually funded the full cost of a student's fees for the year. So we were talking in the 100,000s per student. We then entered a relationship with NSFAS, who's taken on the financial responsibility for the students in a big way, which has been positive. And so our work back commitment now is a little more hazy. We, instead of it being a 4-year work back, it comes down to about 2 years. After a 4-year qualification, we would have spent enough money to warrant them to go back for 2 years. So we find that all our graduates are willing to do that and happy because they get employed back home, and that's all fun. The big challenge is that the Department of Health can no longer employ them, KwaZulu Department, because they are under financial constraints. And so our graduates will do internship. If so, the doctors will do internship, the pharmacists will do internship. They will then do community service, and thereafter the department may not employ them permanently, and they are then left to look for a post for themselves, which ultimately undermines the very thing that we were doing, trying to address the shortage of staff in rural hospitals. However, because the youth unemployment and the opportunities for youth are so dire in South Africa, that the work that we're doing is still empowering youth in a huge way. They will all be employed. They may not be employed where we would ideally wanted them to be employed, but 85%, 87% of our graduates are working in the public healthcare sector. So they are serving the community, the broader South African community.
Thank you. We're short on time, but I think I can go to one more question, right? And that is around, what is the rate of abuse of this offer by students? I mean, you've spoken about how there's a 95% completion rate. So it's clear that, once students are on the program, they are to succeeding, right? But have you seen some students abusing the system? And if so, to what extent?
Okay, fortunately, we don't have many bad experiences. So students will be excluded from our support for poor academic performance or non-compliance, bad attitude. And one of our trustees many years ago, who was the district manager of Umthombo Department of Health, said, if you've got bad students, I don't want bad graduates. We get rid of them now, we don't want them. And so that was a lesson that we learned. I think our big advantages, because we invest in rural youth, the values are incredible. Our graduates, we've got, as we said earlier, 488 graduates. Some of those doctors are now specialists. We've got a guy who's a cardiologist, and they are so humble. They are so incredibly humble. So, and I think that's very much the way they've been brought up in a rural area. So we've seen very, very little abuse. We have not had students receiving our benefit and not attending classes, because that's all compulsory, and they have to meet with a mentor once a month. And if they don't meet with their mentor, that allowance, monthly allowance we were going to pay them, we just withhold it. And then they contact us and say, I didn't get my allowance. And we say, well, you didn't meet your mentor. Or we've heard you're not attending lectures. Tell us your story, what's going on. So we've got checks and balances. I mean, it's really about holding students accountable. You've been given an opportunity. We're here to walk alongside you. And, you know, but if you don't toe the line, then there are consequences. But fortunately, we have very, very little of that.
Fantastic. Well, colleagues, we're approaching the end of this session, and I would ask you to complete the session poll that is going to appear. And while you do that, I just want to summarize this session quickly, right? That this is all about capacitating the healthcare force within the rural setting, and that through this program, there's a 92% pass rate, all right? Supporting students across 16 different specializations. 65% of the graduates go on to stay within the rural setting. So this program goes a long way in terms of increasing the number of qualified healthcare professionals, improving access to healthcare, particularly in the rural setting, and creating a new cohort of mentors and leaders who can inspire the generations that are following you. And Dr. MacGregor, I just want to thank you, and we appreciate your partnership, and we really look forward to continuing on this engagement between yourself and SAMED. There are a number of transformation experts on the line, so if it's possible for you to share some sort of document that they can go back and read up on and discuss within their leadership groups, right? Also create a full opportunity to engage you, right, in terms of how to take this forward.
Yes, thank you so much.
Yeah, and I also want to thank all the delegates for having attended this session, and I want to thank our sponsor too, the Korean Trade Investment Promotion Agency. And with that, we will close with a video from our sponsor. Thank you very much.